Are there any indication, any situations where we might not need PSA, PSMA PET scanning? Like, someone presents with, de novo metastatic disease. Do we need PSMA? Dr. Satpute, I was going to direct that to you.
Yeah, I mean, there are some situations. For example, the initial localized disease, sometimes it might be sufficient to just get an MRI to understand the local disease when you're not suspecting very tiny level of PSA and you don't really suspect anything in the bones. That would be one situation where you could, but again, that space is getting smaller and smaller because I think the PSMA really adds a lot of advantages there. And then there are situations where there is obvious disease and patient is symptomatic with it. In that case, you really would wonder, is it really necessary to? And to be realistic, PSMA PET scans not always available as readily as the conventional. So there are times where you can compromise and try to get these scans done sooner so you can understand the extent of the disease.
And I think it was that latter point that I was looking for, because you see a patient sometimes and their PSA is 5,000 and they have innumerable bone lesions on CT and bone scan. It's like, well, what is a PSMA PET scan going to do to help me manage this patient? So those would be times where I'm like, well, maybe if the patient achieves remission and is in great control, later on I'll get a PET scan, just to see what residual disease is left there. So you mentioned about, Dr. Bhanji, the whole PSMA issue with clinical trials being mostly conventional imaging. I was going to direct this to Dr. Liu about how do we reconcile that? You get all these clinical trials with all their outcomes, and they were using less standard imaging than we use. How do we think through that, as we're managing patients and getting PSMA PET scans with, basically better data than what was on the clinical trials?
Yeah, I think that's an excellent point to make, because a lot of how we grade low volume disease, high volume disease, it comes from the charted trial, which uses just conventional imaging. And so now with PSMA PET scans being more sensitive or more specific for prostate cancer and small amounts of distant metastasis, I think we all have to wonder, what does it mean and what are the implications for staging? There are, trials going on to see how we can work, PSMA PET scan into the paradigm. Radiologists are finding new ways to kind of give grades to PSMA lesions as well. And I think in the future, what that means is we may have different criteria. We may have different, volume thresholds even when it comes to incorporating PSMA into staging. But I think we're moving in that direction. I think it's really exciting to have this tool available.
Yeah, and I think most of us have started to just use PSMA as another, excellent tool, way better than what we believe to be the previous CT bone scan. And so we just use it. Even though it's different than the criteria in the clinical trials was done, it's still just our best test that we can do. That's how I kind of look at it. So PSMA PET scanning can have some false abnormalities. Dr. Bhanji, can you walk us through, what do you think of when you see things that you're not sure is cancer? How do you think through it?
Yeah, exactly. For all the advantages that next generation imaging brings, we do certainly have to be aware of the pitfalls. So commonly in my practice, what I've seen is oftentimes kind of non-specific bony lesions. In patients who have a history of Paget's disease, hemangiomas, fibrous dysplasia, oftentimes this can look like, malignant uptake on PSMA PET scanning. So we have to be aware of that. Another common pitfall is uptake in the ganglia. The sympathetic nervous system does have some PSMA expression. So, the celiac ganglia, the sacral ganglia, these are all areas where, you could have some false positivity.
Especially in the
Absolutely. Mm-hmm. Yeah. And so, keeping that in mind, again, when you have very specific and sensitive imaging, you are sometimes picking things up, which you have to consider in the context of the patient's kind of clinical presentation. And if you do have some conventional imaging that's been performed previously, that context can be helpful.
How often do you guys think that someone is upstaged with a PSMA PET scan compared to conventional imaging?
most of the time.
I think often.
Often, yeah.
like the trial said like 35%, isn't it?
Yeah, gotcha. So I recently had a situation. I was on another panel for prostate cancer, and they presented a case where it was for non-metastatic prostate cancer discussion, and the case that they presented had PET positive, PSMA PET positive, small volume, 1 centimeter lymph nodes. And I made the point that I would treat that as metastatic disease. And some of the other participants said, I'm not sure that's metastatic disease. I'm like, but it's not positive on your PET scan, so that's why you did the PET scan. So, I mean, how do you guys think through when you get small volume lymph nodes? Dr. Gonzalez, how do you work with that?
So certainly it depends on where the lymph nodes are located.
Yeah.
So there are, regional lymph nodes around the prostate that we would consider just a locally advanced disease that we would think differently than if there were retroperitoneals or periaortic nodes or nodes elsewhere more distant in the body. There can be some reactivity to some of those nodes, particularly post-biopsy or post-surgery. Some of those nodes can show a false positive. So we have to kind of take, as Dr. Bhanji said, a clinical picture. Does it make sense? We presented a case the other day, you and I, where the patient had a paraesophageal lymph node that was enlarged and positive on PSMA PET scan, but he had low-grade disease. Everything else in the pelvis was normal. There's one isolated little area. It just did not fit the clinical picture. And to kind of piggyback on what Dr. Bhanji said about the pitfalls of PSMA scanning, I've found it extremely helpful to have a close relationship with my radiologist. There's 1 or 2 people that I discuss these scans with. I review them with them, and so I understand and they understand kind of what do they mean when they say there is some uptake in the 9th rib. Ribs are famously false positive, and we were biopsying these ribs initially on a regular basis, and now we understand that's a kind of somewhat of a normal physiologic uptake from fibrous dysplasia, et cetera. And so I think that close communication with the radiologist is very important. Understanding the patient's clinical history, have they had some kind of intervention that could have caused some inflammatory nodes to be present? Does it fit the normal progression of the disease? Does it fit the pattern? And certainly getting a biopsy in certain areas can be very helpful.
Right, very good.